So this morning, we will be talking about arteriovenous malformations. And just to make it kind of look crazy or to give a visual impact of what really happens, I put these cluttered wires all wound up together to give a picture that inside the brain, the impact of arteriovenous malformations are pretty multifaceted. And it's not just vascular problems we face, but actually we will have even depolarization that takes place because of the steel phenomenon that takes place secondary to a vascular malformation. So let's go ahead and understand this disease better. So arteriovenous malformations are abnormal clusters of blood vessels, and technically, AVMs can be seen in any part of the human body. It's not restricted to the brain. We can have peripheral AVMs, we can have visceral AVMs, we can have AVMs in the uterus or any part of the brain. Now, although they are congenital, we do not see arteriovenous malformations at birth. Very important point to understand. They actually present usually in the second decade of life or maybe 15, 16 years later. Sometimes peripheral AVMs may be seen early, but they continue to grow as the child grows. And it's exactly opposite to hemangiomas. For example, there are rapidly involuting hemangiomas that will rapidly grow within the first year and then they involute. Even venous malformations do not tend to keep growing rapidly, they just grow with the child. But AV malformations are different. You may not see one at all. So if you do an antenatal ultrasound or an ultrasound in early infancy, you will not see an AVM in the brain. And then later on, you may get this child coming to us at the age of 15 or 16 years, either with seizure or a bleed, or maybe incidentally, you'll see an AVM. So we understand, we have not really understood what exactly is happening. It is as though it has been programmed to present itself at a certain age. And sometimes they can present like an angioproliferative disorder, which appears kind of like a small AVM when the child is around 7 or 8 or 10 years old, and then it proliferates across the whole hemisphere. So some parts of AVMs are not being really fully understood. But we will tell you today as what exactly is the pathophysiology, which we have understood very well, though we do not know exactly why is it that suddenly it pops up in a child who looked totally normal when he was born. Also remember, AVMs are not always symptomatic. Especially small AVMs are absolutely not symptomatic. You may not have any symptom in any part of the body at all. At the same time, sometimes they can have a variety of symptoms and some of them lethal. Now, the commonest presentation is a bleed. Now, we'll talk to you in detail as to why an AVM can bleed. And when they bleed, they can present either with a seizure or the patient comes unconscious or with an hemiplegia. And sometimes the first bleed itself may result in death. It can present with seizures. Now, why does it present with seizures? Suppose it's on the motor cortex, it can be a trigger factor by itself. Sometimes seizures takes place because of a steel phenomenon. Because what happens in an AVM is that because there is extremely low resistance in the vascular bed, all the flow is recruited into the AVM and the normal brain does not get blood. So there is no oxygenation. And the anoxia itself can sometimes induce depolarization and the patient may present with a seizure or even sometimes with a lack of mentation. At times they present with what we call as vascular headaches. And that's why it's important if you're doing a CT in a patient with a diagnosis of vascular headache that you always give contrast. A small AVM may be the reason for vascular headache. So vascular headache will present exactly like migraine, but the difference here is there is a definite cause that is inducing this headache. Now, when detected, AVMs are ideally treated to prevent bleeding in the future. Now, this is a very controversial statement. Should all AVMs be treated? Currently, we believe that all AVMs need not be treated, but AVMs in the young should be treated. And that's because there is a kind of bleed rate which is approximately 1% per year. So if you meet a 20-year-old boy or a 20-year-old female presenting with an AVM, the commuted risk of the patient having a bleed, considering he may live up to 80 or 90, will be 60 to 70%. But if you get a 70-year-old man or a 65-year-old man, the risk of bleed falls down to 10% or 15%. So it's not that all AVMs need to be treated, but definitely AVMs in the young should be treated whenever possible when you think the risk of treatment is lower than the risk of bleed. Again, along with that, the angio architecture may give us an idea whether they are prone to bleed. And if they are prone to bleed, then they definitely need treatment because bleeding in AVMs can be lethal. Let's understand the pathophysiology of an AVM. It's a focal area where the capillary bed is missing. Now look at the picture by the side. This is the capillary bed. So technically what happens, blood will flow from the arteries, come to the arterioles and the capillaries and then go to the veins. So all the resistance that is offered to flow is offered at the capillary and the arteriolar bed. This is where oxygen transfer takes place. Now imagine this bed is missing. So the first thing that happens here is there is lack of resistance. By normal law of physics, you know, that flow will always go through the path of least resistance, whether it's electricity, whether it's water, whether it's blood. So thus what happens is blood, instead of flowing down the capillary, will now start going down this low resistant bed. Also, we know that the systolic pressure or the mean pressure in the human body, which is approximately between 90 or 100 millimeters of mercury, will drop to 5 because of this capillary bed. Here, because the resistance is no longer maintained, the pressures in the vein are close to that of the arteries. So the veins, which are not normally used to such pressures, will start hypertrophying, will become ectatic, will dilate. And obviously, all these can induce a rupture either within the segment where the capillaries are missing, and this segment where the capillaries are missing is called the nidus. Thus, to call a malformation as an arteriovenous malformation, it's mandatory that this segment is there, the nidus. The nidus is the area where the capillaries and the arteriolar bed are poorly developed or not developed at all. So what is an AV fistula? An AV fistula is the direct communication between the artery and the vein. You will not have a nidus. When you take a microcatheter to embolize, the microcatheter will go onto the venous side. Why is it important? Because if you're planning to embolize, if it is an AV fistula, we would change the agent because glue will fly really fast. And very often we notice by just taking off the AV fistula, a patient can become asymptomatic, right? So it's important that we understand AV fistulas are direct communication with the arteries and veins. Arteriovenous malformations is an area where the capillary bed is missing. There is a nidus. Remember also in large AVMs in the brain, you can also have multiple AV fistulas within the AVM. And often when we treat, we would first take away the AV fistulas, reduce the flow, and see the symptomatic improvement. And sometimes we would then only go into the AVM per se. So these are the things that are happening. The feeding artery is hypertrophy because there is so much of excessive flow, because it's recruiting blood from all the areas into it. It induces venous hypertension. You could understand that easily, not only in the brain, anywhere. Thus, if you have a peripheral AVM, the patient may present as varicose veins. You'll have surrounding ischemia. And why do you have surrounding ischemia? That is purely because of the steel phenomenon. The surrounding areas do not get sufficient flow, and you will have ischemia, which can present with atrophy in the brain and seizures. The vessels will rupture because especially these vessels are not used to such high pressures, and so much of flow, and aneurysm formation takes place. We told that yesterday. Whenever there's excessive flow, there is more of shear, and more of shear induces more of neural atrophy, and more of neural degeneration will induce aneurysm formation. So I hope you got the basic idea of the pathophysiology of an AVM. How do you diagnose an AVM? Very often you do a CT, you'll get a picture like this. There are some serpiginous calcification present. You give contrast and you'll see enhancing vessels and large draining veins. So AVM diagnosis is pretty straightforward when you're actually doing a CT or cross-sectional imaging. It's not a difficult diagnosis. The only way that you may sometimes get confused is it a dural malformation? In the dural malformation or the dural AV fistulas, you'll also see hypertrophied branches from the external carotid artery, which is never seen in an AVM. Also remember, AVM is always restricted to one side of the hemisphere. You don't see bilateral AVMs. It's embryologically not possible. Whereas in a dural AV fistula, you'll see malformations across. You see a tentorial dural AVF, which is across. You see one in the sigmoid across because it's an acquired condition. And here, since it's congenital, it's always limited to one half of the hemisphere. And like you see over here, all these are limited to one half of the hemisphere. If you do an MR and if you do a T2 image, you will see flow voids. Can you see that? You can see these flow voids. It can be seen in either the T1 or the T2. And if you do an MRA, of course, you'll see this large cluster of vessels. If you do an SWI imaging also, you can see the vessels very well. And if you do an ASL, you will see definitely a much more increased flow. So ASL also works out good for small AVMs just to pick up the AVM. It cannot plan management. You cannot think of treatment, but it has two great advantages. It's pretty sensitive to pick up even small AVMs, but more than that, it's extremely good to locate the AVM. And geographically, sometimes you cannot tell where the anatomical location is. Anatomical location is extremely important because some areas in the brain can be easily sacrificed. For example, you have an AVM in the frontal lobe. You can sacrifice one frontal lobe, nothing much is going to happen. And then we consider it a safer AVM to operate. In other words, the brain has got two sets of areas, the eloquent areas and the non-eloquent area. What's an eloquent area? It's an area that's vitally important for us. The basal ganglia, the Broca's motor speech area, the occipital cortex, the brain stem, the motor strip, and all of these are eloquent areas. The non-eloquent areas are the temporal lobe, the frontal lobe, the cerebellums. So basically it means even if you lose it, you may not have a major deficit. And that's why MR is excellent because it can actually tell you, like in this case, you know that this is coming from the parieto-occipital cortex, which you know is not too bad a point to actually treat unless it's extending onto the motor strip. So come to the question, should all AVMs be treated? The first thing, mandatory, all AVMs that have bled should be treated. Why? Because once an AVM has bled, it will rebleed again and again. Especially after the AVM has bled, in the first year, the bleed rate may increase to 10% against the 1% that we talked about. The second are poorly controlled seizures. Patient is on multiple medication, still having breakthrough seizures. There is no doubt it should be treated. What about an asymptomatic AVM? The rate of bleed is 1% per year in young patients. So because of that, in a young patient, you still suggest treatment if you think the risk of your treatment is lesser than the risk of the patient dying with the bleed. Now, when we do an angiogram, even if it's asymptomatic, these are features that suggest that the patient will bleed. One is an aneurysm in the feeding artery. These aneurysms can rupture. These are hemodynamic aneurysms. We often, if you treat the AVM, the aneurysm may disappear, or you'll have to treat the aneurysm also. Within the nidus, which is within the area where the capillaries are not developed, you can have an aneurysm, and you call that as an intranidal aneurysm. Have you got it? You will call that as an intranidal aneurysm. And if you have an intranidal aneurysm, even then you will have to treat it because it is extremely important. I hope you get what I'm saying. An intranidal aneurysm is an aneurysm within the nidus, and it's important that we treat it because if you don't treat an intranidal aneurysm, they are very, very, very prone to rupture. Very often, when we have a patient who comes to us with a bleed, we will closely look for an intranidal aneurysm. And I'll tell you also, maybe as the talk progresses, the most sensitive way today to pick up an intranidal aneurysm is not CT, it's not MR, it's not even a DSA, but it's a DNSA associated, or when we do a DSA along with a cone beam CT. So cone beam CT basically allows us to take thin slices of the nidus as we inject contrast. And today we know that this is the most accurate way to pick up an intranidal aneurysm. The intranidal aneurysm is a weak spot. It's a dangerous area. They're prone to bleed. And if you see a patient with an intranidal aneurysm, they need treatment, and there is no question about it. The third one is venous ectasia or venous outflow stenosis. So when you have a patient where the veins are grossly dilated, they look aneurysmal, or maybe you got an outflow stenosis, and all these will increase the intranidal pressure, which will allow the nidus to rupture and is dangerous. So remember that the causes for which AVM should be treated, anyone that's bled should be treated, anyone with uncontrolled seizures need to be treated, any patient who's young should ideally be treated unless the risk of surgery is greater than that of the disease itself. Any patient with intranidal aneurysm needs treatment, venous ectasia needs treatment, venous outflow stenosis needs treatment, and also feeding artery aneurysms need treatment, okay? Now, what are the treatment options? One is surgery, which is the gold standard and is still considered the primary form of treatment purely because it's curative. The second is embolization, when we enter into the nidus and try to obliterate. Unfortunately, even today, this is not the first line therapy unless it's a small AVM, because we often can't guarantee that the whole AVM can be obliterated. Also, unlike what people may think, embolization is associated with the risk of post-embolization bleeds. And these are devastating bleeds because of reperfusion. As you block the nidus, now blood gets rerouted into the normal vessels, and this rerouting can induce a very, very large bleed at times, which is fatal. And finally, you got stereotactic radiosurgery. What is stereotactic radiosurgery? Basically, it's passing several hundred beams across the cranium, all of them meeting at a single focal spot, and the focal spot is the AVM. So individually, the radiation dose of each beam is not high, but at the focal spot, it's extremely high. It's a single fraction that is given, and it's curative. But the only problem is SRS takes 2 years to cure, and so you cannot give it in a patient who's bled, who's got the highest risk of bleed in the first year. So you got it, surgery is the first line therapy and should be offered first for all AVMs, even unruptured ones. Embolization is usually a treatment option given to either downsize the AVM for SRS or make surgery easy, or sometimes for small AVMs, it can be curative. Although, especially in Europe, there are people are using this predominantly as the first line approach. That is more because not many surgeons in Europe are interested in operating AVMs. They take long hours, it's a risky surgery. Otherwise, in general, across the world, surgery continues to be the first line therapy. So like I said, surgery is the first choice since it's curative. What are the limitations? You cannot operate when the AVM is an eloquent area. You have an AVM in the motor strip, at the end of the surgery, the patient will have a stroke. An AVM in the Broca's area, he'll start speaking. If it is sitting on the brainstem, it is impossible. You'll have a dead patient, or in the basal ganglia, you cannot treat. Once the patient has deep venous drainage, you cannot treat, because you cannot dissect and go down the deep vein, because you can have a disaster. Very large AVMs also are technically close to impossible to treat, and that's why embolization plays a role in downsizing it. What about stereotactic radiosurgery? Stereotactic radiosurgery can be done by several equipment. For example, the one in our hospital is a linear accelerator with advanced features done to enable them to do stereotactic radiosurgery. Then we have got the cyber knife, which is a tool dedicated to do stereotactic procedures, including stereotactic radiosurgery. So we basically have another tool also, which is called the gamma knife. That also works in the same way. It's like, looks more like a large helmet onto which you put the patient's head and the beams pass through, and the principle continues to be the same. But remember one thing, you will do, whenever you do an SRS, it takes 2 years to obliterate, and thus it's not ideal for AVMs that have bled. Since it takes 2 years, you can't be doing it on a patient who has bled. So you can't produce instant results. And also there's a limitation of size. Beyond 3 centimeters, it becomes technically challenging. I know in a center, they go up to 5 and they do fractionated sessions, but in general, it is limited to 3 centimeters. So we got these issues, but yet it's a great tool. And you will see during the course of the talk that how often we use SRS. Now, embolization. Remember, it's not the ideal choice since it's rarely curative. In 30% of the people, we can afford cure. Today, with better evolved techniques like a venous approach or using a technique called the pressure cooker, which I'll be talking later, we can offer cure. But remember, the complication rates currently are higher than that of surgery and definitely much higher than SRS. So it is something we need to understand. The goal of treatment is not just curing the patient, but also having a live patient at the end of it and a functional patient at the end of it. So today, by all standards, we do not or should not consider embolization as the first line therapy unless and until it has got a distinct advantage over the other two procedures. And we, like I said, that these are debatable. Even today, like I said, the French group would not believe this talk because they do not operate AVMs. All of them go for an endovascular procedure. So when we talk about embolization, but there are some forms of embolization which are accepted beyond doubt to be the first line therapy. And one of them is called rescue embolization or targeted embolization. It reduces the size of the AVM to make it treatable for surgery. But more than that, it obliterates a weak spot in an AVM in an eloquent area, and then we treat it as SRS. So I've got a basal ganglionic AVM. There is an intranidal aneurysm out there. It cannot be operated. I target and remove the intranidal aneurysm alone, and that is targeted embolization or rescue embolization. Now I have a patient who had a high risk of bleed to be transformed to a case which has low risk of bleed. Now I send the patient for SRS, and they will tolerate the 2 years waiting period because the primary weak spot has been taken out. Now this is called rescue embolization. Rescue because otherwise the patient would have died, and I can stop that from happening by going to the target and embolizing it. So let's move on. As radiologists, how do you report an AVM? And this is something which every radiologist should know, right? So we have a grading system. It's been not made for embolization. This was planned for surgery. It's called the Spitzler-Martens grading system. One, you give a certain amount of marks. The first set of marks go for the size. Is the AVM the nidus of the AVM? That means the part before it goes into the veins, less than 3 centimeters, give it 1. If it is between 3 and 6 centimeters, give it 2. If it is greater than 6 centimeters, give it 3. Can you remember 3, 6, and 9? Is it involving the non-eloquent area? You give it a 0. If it is in the eloquent area, give it a 1. If the venous drainage is superficial only, give it a 0. If it is deep, 1. So suppose somebody's got a large AVM in an eloquent area with a deep, this thing is 5. So the largest score you can get is 5. You got this point? So as the numbers increase, the surgical risk of death and deficit keeps increasing. So you got somebody with a 1, 0, 0. It is good for anything. It is in the non-eloquent area. It's really small. You can embolize it. You can SRS it. You can surgery it. All of them will work pretty good. But in that case, if the patient has no symptoms, we can still send it for SRS unless it's so superficial that surgery is easy. Okay, I hope you're getting the hang of what I'm talking, right? So we got a grade from 1 to 5. Greater the grade, greater the risk at surgery. Now, so we understand that this grading system that I'm talking about is like this. Grade 1, the size is 1, the eloquence is 0, and the venous drainage is 0. Now, look at this. This is grade 2. Now, you can have several variables. The size is less than 3, but the eloquent area is 1, and the venous drainage is 0. Or I can have a size of 1, it's small, and the venous drainage is deep, it still is 2. Or I can have a size which is 3 to 6, eloquence 0, venous drainage 0. So if you look at it, it's not one of the greatest classifications, because we know that even if it's in a non-eloquent area, if the venous drainage is deep, surgery becomes difficult. But still the surgeons love this, and we are expected to report this, whether it's an angiogram or whether it's an MR you're reporting or a CT you're reporting. You have to give the Spitzer matrix grading, and you will do it. When we come to 3, but just remember this bottom numbers that I put here, the mortality keeps changing. For example, in this case, surgical mortality is 4% and morbidity is 5% in a grade 1. Now, if you go to the grade 3, mortality goes to 11% and mortality goes to 15%. Now, these are larger AVMs. It could be size 3, eloquence 1, venous drainage deep. Cannot go for surgery. Size 2, eloquence 1, venous drainage superficial. Size 2, eloquence 0, venous drainage 1. Size 3, you get a point, either one of them, the mortality and the morbidity keeps increasing. I hope you got the hang of it. It's pretty straightforward, not at all difficult. You just got to add 3 numbers together, and in the end, you'll get an answer and you can get it. Like they've shown these pictures here, huge AVM out here in the frontal lobe, none of them eloquent, all of them cortical. Technically, it's an AVM that you would like to embolize, reduce the size, and send it for surgery or SRS. But when you come down here, when the venous drainage is into the deeper veins, then surgery becomes very difficult. It's a deep AVM, and then the choice is only between SRS and embolization. Class C, now this, the morbidity and mortality changes from 21 and 28. Basically, even larger, where you eloquent, large AVM, deep venous drainage, everything is working against you, and you'll get an AVM like this, right? I'm not going into the details of it because it's very easy to understand. You hit 5, it's going to be the worst, and it is grade 5, and this is grade 4. You can see the number is 4 out here, and this is 4 out here, right? So the first thing you will report is the Spitzer matrix gradings. Pretty straightforward. You look at the size, you look at the location, you look at the venous drainage, whether it's superficial or deep, and you give a score and you report. The second thing is the venous anatomy, extremely important. One, is the drainage to the superficial system, or is it to the deep system? Is there periventricular drainage? Seen, they tend to bleed a little more. If there are multiple or single veins, remember, it's better to have multiple veins than single veins, especially if you're doing an embolization procedure, or even for it's better and safer if there are multiple veins. At the same time, if you're planning to do a venous approach, it's better if there's a single vein. A surgeon is happier with a single vein because ligate only a single vein. So whatever the reason is, draining veins are very important, and you have to tell single cortical draining vein, multiple veins, periventricular draining into the deep system, isolated deep draining vein, or whatever it is. The next thing you look is there ectasia of the veins? Whenever there's ectasia, we understand one thing, this patient is going to bleed and he needs early treatment. The next thing you'll report is the venous outflow stenosis. Because of the increased flow, a kind of intimal hyperplasia takes place, and the outflow can get stenosed, and that is a dangerous condition because the intranidal pressure will increase and it will rupture. So remember once again, you talked about the speeds of monitoring grading in your reporting. Now you move to the venous anatomy. You tell whether it's superficial and deep, how many veins are there, are they periventricular, is there venous ectasia, is there outflow stenosis. Have you got it? Pretty straightforward, not too complicated at all. Then you look and see, is there an intranidal aneurysm? Very difficult on CT, very difficult on MR unless it's large. And that's why I said when we do an angiograph, we do a cone beam CT, we slice through the nidus in multiple directions, and then we try to see, can you pick up a nidus? This intranidal aneurysm is crucial because these are always prone to bleed. The second thing is a feeding artery aneurysm. These can also bleed. This also is a dangerous condition. So your report will be complete now. You'll talk about the speeds of Martin grading. You'll talk whether there are feeding artery aneurysms and intranidal aneurysms, yes or no. And then you will talk about the venous outflow and talk whether it's deep, if it's superficial, they're multiple, if they're single, the ectasia, whether there's outflow stenosis. Have you got it? Now, if you got all those parameters together, it's fine. And remember always, you will write the location of the AVM, and that is also an important finding. So we are going to talk about embolization because we are radiologists and we got to focus on this. So how is embolization done? Embolization done is taking a microcatheter into the nidus and injecting this black looking liquid, gooey liquid, which is a DMSO based compound and which is either called Onyx or it's called Squid, or today we have an Indian company selling an agent which is called Minox. Basically, all of them are the same. All of them look black because of tantalum powder that is there. It is a form of glue, but it doesn't polymerize so rapidly inside the blood, so it can be in a semi-liquid state for quite some time. Cure in small AVMs is 60%. Actually, today with the technology we have, we can touch even 80%, but in large AVMs, it's only 20 to 25%. That's a problem. So it is a non-adhesive liquid embolic agent. So why non-adhesive? The other agent we use is something called NBCA, neobutyl cyanoacrylate, which is a super glue. Super glue, you put a skin together, it would stick. If you drop it across and skin that have been cut, it behaves like an adhesive out there. So it's a non-adhesive liquid embolic agent for embolization of peripheral arteriovenous malformations and for any AVM. They are basically composed of ethylene vinyl alcohol copolymer. We talked about a particle called polyvinyl alcohol sponge. This is called ethylene vinyl alcohol, which is suspended in micronized tantalum powder for radiopacity and dissolved in DMSO, which is dimethyl sulfoxide. Now, DMSO is an industrial solvent. So one problem with DMSO is many plastics will melt. So it's important that we take a syringe or if we take a catheter that we look on the label which says it is DMSO compliant. If you don't do that, the catheter will melt. You'll have a melted catheter and it will break inside the body. So DMSO is a chemical solvent and it's to be used only with plastics or material which are compatible with DMSO. It comes as 1 ml vials, and this is how it looks, pitch black. And because the tantalum powder is actually, it's a powder, we have to put it into a shaker, which will be vibrating to suspend the tantalum. Otherwise, we cannot see it as we inject. So we slowly inject this inside a blood vessel. After some time, this will reflux into the main artery. Then we wait for some time till it forms a plug. And then we allow this to go only forward, and I'll show you some pictures. The other agent we use is NBCA, neobutyl cyanoacrylate. This is actually super glue. The problem is it polymerizes immediately, but it forms a coagulum. So you can never really take out an AVM to accept the main feeding artery, the proximal part, but it works very, very well for fistulas, where there is only a small segment to be taken and it's very fast. The problem, it's not radiopaque, so we mix it with lipidol, which is basically poppy seed oil in iodine, and that is titered. Like we say, 1 part of glue, 3 parts of lipidol. So we have a 25% glue, which is kind of dilute, and we use it more for tumors. Whereas when we come to AVMs, It's one part glue, one part NVCA, and we use it for AVMs. And when we are going to use for AV fistulas, it will be 3 parts glue and 1 part of lipidol, and that becomes really concentrated. It will glue really fast, and we use it for AV fistulas, right? So we can tighten this and use it along with lipidol. For example, have a look at this. We do a picture like this, and we see something like this, and we are not sure what exactly it is. Now, why is DSA the gold standard? One thing, it tells us the size, it tells us the location, it tells us the draining veins, it tells us the aneurysms, it tells us the venous outflow. So everything that you basically want is available on a DSA because you can catch it frame by frame. The early frame is purely arterial, the late phase is purely venous, so which is not possible today on a CT or MR, even in the ultra-fast CTs, because there will be superimposition of images that take place, making it difficult for us to come to that conclusion. Let's go further on the diagnostic workup that we do. Now look at the advantage. Now this is a DSA. Here is a picture. You have a vessel, you definitely have a nidus, and this is what is seen. Can you see the late phase? This capillary blush-like thing that you see is a nidus. Look at this. It's a vessel. It directly goes to a large venous sac. This is an AV fistula. This is an AVM. Why? Here you got a nidus. Here you don't have a nidus. This is difficult on a CT and an MR because of superimposition that takes place. The treatment is radically different. In this, we'll use concentrated glue. In this, you're going to use something like Squid or Minox. The same one, whenever there is an AV fistula, the treatment is always, embolization. So this is what we do. We've got this microcatheter that you bring it all the way. Can you see the number of loops, turns? Looks very impressive, right? Yeah, technically the catheters are so amazingly good today that reaching this fistula will not take more than 20 minutes or 25 minutes. That's it. The same thing when we did 30 years back would take us 3 hours. Honestly speaking, it would be so crazy that everybody would be exhausted. And I still remember the time I was training in Sri Chitra Tirunal, one of the sisters used to always tell us, whenever you're doing one of these, please let me know before. I rather catheterize myself and come. It used to be such long procedures. But believe me, today, reaching these target sites do not take any time at all, thanks to the technology that we have. So we have this, we come inside, and this is injecting glue. Like I said, this is the end result. Have you look at it? Completely gone, totally cured, and this is the glue cast out there. And the glue basically in this would be 75%. It's really concentrated glue. We just inject it and come off, and it's really fast. Remember one thing, catheters get glued to the glue cast itself, so you got to pull it out fast. But remember, AV fistula is generally treated with glue, NVCA. We hardly use Minox or Onyx to treat it. But in an AVM, it would change completely. Now let's look at angio architecture. We talked about intranidal aneurysm. This is an intranidal aneurysm in a patient who's getting the supply from the perforator. So this is an AVM involving the basal ganglionic region of the left side and extending outwards. Now this is the point that is bled in this patient, and this is targeted embolization when you take this out. Feeding artery aneurysm. Can you see all these arteries, large aneurysms over here? This is called feeding artery aneurysm. This was a patient who had come with the posterior fossa bleed. I just want you to understand that these are dangerous. Can you see this big aneurysm? Big aneurysm. This is not inside the nidus. It is in the feeding artery. This is venous stenosis. Can you see the outflow? The very tight stenosis out here. When you see a venous stenosis like this, it is dangerous. Patient needs treatment. And this is venous ectasia. Can you see that huge sacs that you see out here? Whenever you see venous ectasia, also you need treatment because they are also prone to bleed. And often we see venous ectasia in patients with AVMs. So when you talk about embolization of an AVM, we would classify this as arterial or venous. Arterial is the conventional form of embolization. What we do out here is basically we would go from the arterial route, and this is conventional. It usually results in incomplete cure when the AVM is moderately large. Technically, it's less challenging. AVM anatomy is not very significant, so we can go ahead and treat. Whether it's what we may anatomy, whether it's one feeder, two feeder, whether it is multiple draining veins, it doesn't make a difference. Venous is very recent. It results in complete cure in several group of patients, but there is a problem. There's a very high chance of bleed if you do not complete it. You have to complete it because the outflow is blocked. He's going to bleed, and there is a problem. Technically challenging. You have to stop the inflow by using balloons or coils or glue, then come from the outflow and again restrict the flow and then inject. I'll show that in a little more delay. Ideally should be done with one dominant draining vein. Large AVMs again cannot be treated because they can never have one dominant draining vein. They'll have several draining veins and it becomes very challenging. So from here, let's go to some cases. This is a cerebellar vermian AVM where we did an embolization. This is a 46-year-old male. He's come with recurrent cerebellar bleeds. MRI shows an enhancing tuft of vessels in the cerebellar vermis. Have a look at this. This is the patient. And you can see the tuft of vessel out here in the vermian region, which is enhancing, which is very well seen over here. Small, but it has been bleeding. Have a look at it. You can see it better and better now, right? Okay. We do a 3D angiogram. We have the advantage in a lab. We have something called 4D angiogram because we can do a 3D in every phase. That is truly beautiful, very, very useful. And this is the vermian angio. Can you see this? The supply of this would be coming from the posterior choroidal artery. And it is a Spitzer Martens 2. The size is small, but it is an eloquent area. And I'm not sorry, the size is small, the drainage is deep, vermis is not an eloquent area. The arterial feeders from the superior cerebellar artery and from the right pica was also giving a supply, and drainage was into the straight sinus. So we plan to do an endovascular embolization through the arterial route. Now I want to show you a very, very interesting technology in the manufacture of catheters. Now, these are detachable catheters. This is called a fuse cath. You take it, you do the gluing, and you pull it out, it will detach at this point, making it safe for the patient. I had a patient who bled when I pulled back the catheter. The nidus of the AVM ruptured, and that is a dangerous condition. It's an on-table death. It's horrendous when it happens. So fuse cath is basically a catheter made by a company called Balt. Another catheter called Apollo is made by another company called EV3. Both of them functionally do the same thing, that they will detach at one point. And that makes it very, very safe when you are treating with a liquid embolics, which will glue the catheter together. So you need a 6-pin long sheath. You need a guiding catheter. We have a detachable catheter. In this case, we use Apollo, or it could be also the fuse cath over here, which we talked over here, which again works in the same way. Then you got the wire for handling these. These are very, very fine wires, and the liquid embolic agent called Onyx. So here is the microcatheter. Now in this microcatheter, if you see, there are multiple dots. Can you see? There are many dots. This dot is the zone of detachment. Can you understand? This is the zone of detachment. You're injecting the glue. Can you see the end result? You're completely taken off the AVM. It is a curative procedure. It is a curative procedure. Have a look at this. An excellent result. See the small AVMs, we can technically do it. This was a branch from the superior cerebellar artery. It is convenient to do it. And you understand, when you're injecting the liquid embolic agent, you don't have to go to every branch. It will actually distribute itself into the nidus and give a curative result at the end. So here it is, a complete result, and it's very good. So why did we not do SRS? Because it has bled. If that not bled in this location, we would prefer to do SRS. Can you see that here, a complete cure? Okay, no neurological deficit. We discharge the patient at day 3. Now here is a patient, it's a right frontal AVM. He's asymptomatic. The draining veins are all superficial. Can you see that? There's nothing into the deep system. We do a cone beam CT. This is the CT. The advantage, like I said, it shows very, very high level of delineation of the nidus. We send it for surgery. Why? It's a non-eloquent area. We get an immediate result of cure. We don't have to wait for 2 years. We don't have to do any of these things. And it's a very, very safe area. It's cortical. It's a Spiegler-Martin grade 1, and it's a safe surgery. And that's exactly how you should approach. Look at this. This is in the post-central gyrus. Okay. Now, this area is not a safe area to treat because you're worried whether the patient can have any deficit at the end of the procedure. Here it is. This is a cone beam CT with superimposition onto the images that come. Very, very good. Can you understand? Actually, it is right over here, and we know this is the motor strip out here. So we would send this patient for SRS. I mean, this is not the SR of the same patient. Just to get you an idea, this is what happens. It is focal. Why? Because this patient is sitting on the motor strip. If anybody does anything else, we'll have a problem. We'll end up in the patient having a stroke, and that will be devastating for the patient. Or for example, look at this. This is a corpus callosal AVM. This patient has come with a very large bleed. Why is it? Because it's hanging right into the ventricle. Do the DSA. The AVM is so small. Can you see that? But the fact is, it has bled. So its size is not the important thing. The fact that it has bled makes it a candidate that definitely needs treatment. This is the microcatheter that comes into the AVM, and we take a Dyna CT. Now the important thing is we want to confirm for sure, has this bled? Now we can make out it's bled because you can see the ventricles. This is on the roof of the ventricle. So this is a Dyna CT or a cone beam CT taken as we inject contrast, and we confirm the finding without any doubt. This is the point that is bled. This is the cast of the liquid embolic agent, and this is the end result where we have cured the patient. See that? So understand one thing, in small AVMs, it's curative. There's no way that you cannot treat it, and 99% they will be cured. Or for example, look at this is a patient with intracerebral hematoma. You can see the small residual AVM out here. After evacuation, the patient comes back to us post-embolization, completely taken out. So small AVMs can be treated. Then we come to targeted or rescue embolization. And this is what I showed you. Here is an intranidal aneurysm coming from a perforator, which is a dangerous branch. And if you inject prox into this, there's a risk of stroke. But here, when there is an AVM, it is a non-functional vessel because there is no capillary bed. So this is the Dyna CT. It shows us the intranidal aneurysm over here. It also shows it sitting adjacent to the roof of the ventricle. Now, entering into a perforator is very difficult. I'm just telling this in case there are some interventional radiologists listening to this, that it is very challenging to enter into this bend. So we use a balloon. We inflate the balloon so that the catheter will not slip out. We cannulate the perforator, and then we take the microcatheter inside. So this is what we're trying to do. This is the microcatheter that has gone beyond now. And once we take this S-bend and go beyond, we come to safe area. And this is the injection being made there. And this is after we injected glue and we took off that nidus, that intranidal aneurysm completely. Can you see that the intranidal aneurysm is not there? There is residual AVM. We have converted a dangerous AVM into a safe AVM. And this is targeted embolization, right? Or it is rescue embolization. And you must understand this. This is an excellent way to manage complex AVM. And then we send it for SRS. The thing is, you can see the glue cast. It is sitting on the roof of the ventricle, telling us very, very clearly that we've done the job and it won't bleed. Sometimes we do it to downsize an AVM. 69-year-old female with hemiplegia. Contrast CT shows a frontoparietal AVM. Look at that. It's actually more of a frontoparietal, more of a parietal AVM. It's large. So what do we do? The size is too big for doing an SRS. So now we will go and embolize it. This is a post-embolization picture. Can you see the size? There's very little left. You can send the patient for embolization for SRS now. Now the size comes within the range that he's comfortable with, and he does it. Or have a look at this. This AVM is pretty tight, the nidus here, but the problem is this component. This component is the one that makes it difficult for SRS. This is an unruptured AVM. We just go ahead and embolize this component alone. Once you embolize this component can be easily tackled with SRS. So have you got it? So you get the hang of it. You get a concept of how we work with AVM. Sometimes we cure, sometimes we take off the weak spot, sometimes we downsize it and send it for surgery. For example, this is a large basal ganglionic AVM, very, very large. So what do? We start downsizing it by injecting it in many peripheral locations, reduce the size of the AVM, and then we will send it for surgery. And then we will send it either for surgery or for SRS. So get this point. So sometimes the large AVM in the frontal region, we can reduce the size, send it for surgery. Suppose the large AVM with some fistulas which are producing very high venous pressure, we take out the fistulas and send it for surgery. Sometimes they're accessible and they have already bled, we'd embolize it completely and then make it a curative procedure. So it's very difficult to actually treat an AVM by one modality. Unless you're small, where it's technically possible to cure it. Otherwise, in general, in most centers, we use multiple modalities. We may use embolization and surgery, embolization and SRS, embolization, surgery, and residual AVM treated by SRS. Sometimes you can use all three, sometimes you can use one. It's very, very similar to treating cancer. You don't have a patient with a breast cancer comes to you and say, only surgery. No, it doesn't work. We would have to use all the modalities to ensure that the patient is cured. Let's talk a few things about venous approach. We have not done venous approach in a center. We have done pressure cooker techniques. Now, this is a technical note I took from Dr. Pereira. Dr. Pereira works in Toronto, one of the leaders in neurointervention, the first person to use a robotic approach for doing aneurysm coiling. And this was a technical note that he put, but it explains it very well. This is a patient who's got an intraventricular bleed secondary to an AVM in the Vermian region, or rather secondary to a bleed, secondary to an AVM in the thalamic region, which is supplied by the posterior choroidal artery. Now, this is the planning of the AVM. You can see that DSA has been superimposed on the MRI, and he has realized there is a good direct vein that is coming straight to it. So his plan is to use this technique. So here it is. He plans to take this catheter and place a balloon into the distal segment of the superior or the PCA so that the flow stops completely. That is important for doing a venous approach. We can't be having forward flow. And he plans to go from the sigmoid down here, come down the straight sinus and enter into this draining vein that is located here. So this is it, into the draining vein from here. And also anteriorly, he's got the arterial route, he's got a balloon out here. And then he injects glue, very similar, like we inject into the artery, this time from the vein backwards, right? This is a small one. He got a good cure out of it. And so this has become pretty popular. Even today, but the vast majority of people will use it in cases like this. Difficult to reach arterially, single draining vein, access that, temporarily stop flow in the artery and treat it. But you can do this also from a technique called a pressure cooker technique. This is again from China, but we use the pressure cooker technique also in the arterial system. But what is the pressure cooker technique? The pressure cooker technique involves two catheters. One is a detachable catheter. Can you see this is a zone of detachment, which is kept really distal into the nidus. Second is another catheter, which we keep proximal and we put multiple coils. Once we put multiple coils, sometimes, at least when we do it from the arterial side, we also inject some glue and block it. Then when we inject, everything goes forward. Now this becomes especially important on the venous side. So here is an AVM out here getting supplied from the choroidal vessels, impossible to access from the arterial side. So he just put a balloon out here to block the top of the ICA, and he comes from the venous side. So here it is. This is coming from the venous side into the deep system. You can see the detachable catheter and the second catheter. Then they put some coils. Here are the coils. And beyond the coil is the catheter with the glue. And then now this has been blocked. You inject the glue, keeping the balloon inflated. We got this idea, balloon inflated, so no forward flow. You do that and you inject it. And now there is no forward pressure. Retrogradely fill it up from the venous side. So this, like I said, is dangerous, may bleed. And today worldwide, people predominantly use it for AVM that cannot be accessed from the arterial side. But remember one thing, having said that, in Europe and in Germany, people use this for all kind of AVM. They use the arterial route, they use the venous route, and the combination is to cure it. Like I said, somehow for some reason, especially in France, hardly anybody operates. Most of them come through endovascular route, but otherwise it's a combination of three modalities. Okay, this was the post-TSA in that case, the basal ganglionic AVM completely gone. Remember, this is bled. If it is not bled, it is going to be SRS. So in conclusion, what can we say? AVMs are congenital vascular anomalies. All AVMs need not be treated, especially in the elderly, we don't treat them. And if the risk of treatment is high, we wouldn't treat them. Symptomatic AVMs in young patients need treatment. Treatment requires detailed understanding of the architecture and the anatomy. Curative therapy is not possible with a single modality in several cases. Surgeons, interventional radiologists, radiotherapists need to work together to ensure appropriate therapy. So just to get people to understand, if this is an AVM, you need everybody. You need the IR group, you need the surgical group, you need the radiation group, and together we can actually make a difference. I just quote from what Michael Jordan had said, and I think it's very important in our life, that with talent, you can win games. But teamwork and intelligence wins champions. Even in a hospital, even in a department, even in your workplace, remember, try always to learn to work like a team. Teams are the people who truly, truly are the winners. Okay? So I hope that you could understand the fundamentals of AVM treatment. And like I said, it's not too complex when you understand it, but as you treat it, you will understand more and more about this disease.